Hello everyone in Cardiomind's channel and welcome to the 8th video in the guidelines of acute coronary syndromes, and today we are speaking about an interesting topic regarding the technical aspects of invasive strategy. We are covering today the percutaneous coronary intervention PCI, the coronary artery bypass grafting that sometimes we use in acute coronary syndrome, spontaneous coronary artery dissection, and the issue and the debate of multivessel coronary artery disease. Let's start with the PCI. First of all, regarding the vascular access, we need to know that about 30 to 70% of the total bleeding events during PCI are due to access-related bleeding. The Radial trial discussed this issue and the Matrix trial, and they showed significantly lower rate of access site related bleeding and surgical access site repair and blood transfusion with radial access compared with femoral access. And so far there is a strong evidence showing that reducing access site bleeding event with the use of radial access is translated into significant clinical benefits. That's why there is a recommendation that radial access is recommended as a class 1 to be the standard approach, unless there are other considerations to use femoral access. For example, patient with hemodynamically unstable status and acute coronary syndrome. In this case, femoral access is much easier and shorter in duration to undergo emergent revascularization, and depending on some technical aspects during the index PCI, for example bifurcational stenting, in this case femoral access would be much easier and convenient for bifurcational stenting and final kissing balloon inflation, but the rule is for radial access. Regarding the culprit artery, the recommendation is for stent deployment in the infarct related artery during the index procedure in STEMI patients undergoing primary PCI. We all know this information. Regarding the non-culprit artery, what are we going to do with it? We are going to discuss this issue in the topic of multivessel coronary artery disease. Needless to say that drug-eluting stents are now recommended in preference to bare metal stents, which are rarely used nowadays. This was shown in the NOR-STENT trial, Comfortable MI trial, and the Examination trial. They all showed the clinical superiority of drug-eluting stent regarding the incidence of reinfarction, target lesion revascularization, and stent thrombosis compared with bare metal stent with no treatment effect by acute coronary syndrome presentation interaction for the primary endpoint. So still drug-eluting stents are recommended and preferred to bare metal stents even in STEMI and non-STEMI. What about drug-coated balloons that are frequently used in patients with chronic coronary syndrome and in-stent restenosis? The Revelation trial and the PEPCAD non-STEMI trial, they were small single-center studies that showed non-inferiority of the drug-coated balloon to drug-eluting stents. But the use of these balloons in non-ST elevation acute coronary syndrome requires further investigation and evidence in order to inform future guideline recommendations. That's why there are no specific recommendations so far to use drug-coated balloon in acute coronary syndrome. What is the role of intravascular imaging? We have the intravascular ultrasound, IVUS, and the optical coherence tomography, OCT. Why do we need them? In some cases of acute coronary syndrome, they don't have significant obstructive coronary artery disease on the coronary angiography, so we need intravascular imaging to exclude or confirm an atherothrombotic cause in the main coronary arteries for potentially lifelong antithrombotic treatment. And in some cases there is an ambiguity regarding the culprit lesion. What is the culprit lesion? In this case, it may be present in more than 30% of patients with suspected non-ST elevation acute coronary syndrome, and more than 10% of patients may have multiple culprit lesion. That's why IVUS and or OCT may help us to determine what is the culprit lesion. So there is a class 2A recommendation for intravascular imaging to guide PCI in acute coronary syndrome, and class 2B to use intravascular imaging, preferably OCT, in patients with ambiguous culprit lesion to determine which is the culprit vessel in order to undergo PCI for it. In this interesting diagram, we can see here that in patients with clear culprit lesions suitable for PCI, intravascular imaging has a class 2A recommendation to guide PCI, and in case of there is no culprit lesion, so intravascular imaging may be used in case of ambiguity regarding the culprit lesion. For example, patient with multivessel disease, hazy lesion, calcification, tortuosity or eccentricity, and some cases it may determine if there is an erosion in the plaque, rupture, nodule, spontaneous coronary artery dissection that is not visible on the angiography, or in sometimes there is no lesion at all. Regarding the intravascular physiology like FFR or IFR to determine the functional significance of the lesion, it is used in patients with acute coronary syndrome to assess the hemodynamic significance of intermediate severity non-infarct related artery stenosis. So we don't use them for the infarct related artery. However, PCI of the infarct-related artery should not be deferred based on invasive epicardial functional assessment, because the coronary microcirculation begins to recover within 24 hours of primary PCI, and so acute functional assessment of the infarct-related artery may underestimate the true hemodynamic severity of the coronary stenosis. So we do not use intravascular physiology for the culprit vessel, but we can use it for the non-culprit vessel. And the big no that the routine use of thrombus aspiration is not recommended. This is a class 3 recommendation. In a sub-analysis from the total trial, it did not improve the outcomes at 1 year. Moreover, it was associated with increased rate of embolic stroke in those with high thrombus burden. However, in case of large residual thrombus burden after opening the vessel with a guide wire or with a balloon, the patient still has no adequate antegrade flow to insert a stent. In this case, the thrombus aspiration may be considered to reduce the thrombus burden and reveal the antegrade flow in order to insert a stent and get a TEMIS flow. Now let's move to the coronary artery bypass grafting. We are not going too much in this topic as the recommendation here is clear. CABG should be considered in patient with an occluded infarct-related artery in a STEMI patient when primary PCI is not feasible or unsuccessful and there is a large area of myocardium in jeopardy, for example in cases of extensive anterior STEMI. In cases of very high risk non-ST elevation acute coronary syndrome needing immediate revascularization, still PCI is the first choice unless there is concomitant mechanical complications necessitating surgical intervention to repair the mechanical complication and to insert a graft on the occluded infarct-related artery. And in other patients with acute coronary syndrome and multivessel disease, the choice of revascularization modality should be made according to multiple factors like the number of affected vessels and the general principles of myocardial revascularization, and we are going to cover this topic in the multivessel coronary artery disease. Now let's move to one of the famous and not uncommon clinical situations to see in our clinical practice. Spontaneous coronary artery dissection is an infrequent cause of acute coronary syndrome in general, but it accounts for a significant proportion in young middle-aged females, especially during pregnancy and postpartum periods. Until there is an evidence from ongoing prospective trials, still those patients should receive the same pharmacotherapy as other acute coronary syndromes. So there is no difference so far in the antithrombotic treatment. And the first choice is for conservative medical treatment as opposed to PCI, because here coronary complication following PCI may occur in more than 30% of patients, and it makes sense. If you try to insert a wire in patient with coronary dissection, the wire may pass to the false lumen, so increasing the dissection and increased liability for obliteration of the true lumen and increasing risk of coronary perforation. So PCI is only recommended for those with a spontaneous coronary artery dissection in specific conditions. The patient has symptoms and signs of ongoing ischemia and a large area of myocardium in jeopardy with reduced antegrade flow. So we don't undergo PCI unless there is flow-limiting coronary artery dissection. If it is not flow-limiting, so go for medical treatment. There are some useful strategies for those patients to minimize the coronary complications. For example, minimal balloon angioplasty to restore flow without stenting, or just target stenting to seal the proximal and distal ends of the dissection, and extended stent length sometimes to prevent propagation of the hematoma in case of extensive dissection. Sometimes CABG is recommended. For example, the dissection affects the left main itself or two proximal vessels. PCI is not feasible or unsuccessful, a common indication for CABG, or patients still having symptoms and signs of ongoing ischemia. The problem with CABG is that there is a significant rate of graft occlusion at 5 years, reaching 68%, because the dissected coronary artery is more prone to anastomosis failure in case of spontaneous healing occurring in the dissection, so restoring the flow in the native vessel, resulting in occlusion of the graft. That's why some surgeons prefer using venous graft in case of spontaneous coronary artery section, because there is a high rate for graft occlusion in order to reserve the arterial graft in case of failure. A large debate regarding the revascularization in those with multivessel coronary artery disease. We are going to divide this topic into specific situations and how to deal with each one of them. The first situation, a patient with acute coronary syndrome complicated by cardiogenic shock, either STEMI or non-STEMI, and we have undergone coronary angiography showing multivessel coronary artery disease. What are we going to do? The famous shock trial compared emergency revascularization for those patients with the initial medical stabilization in those with acute MI complicated by cardiogenic shock. The result that there was no difference in mortality at 30 days, but mortality was significantly lower at 6 months in the group assigned to revascularization in comparison to medical treatment. So there is no doubt that those patients need immediate angiography and PCI if feasible, and in case of the PCI is unsuccessful or unfeasible, so we go for emergency CABG. But should we revascularize the culprit vessel only or also the non-culprit vessels? This drags us to the culprit shock trial that included acute coronary syndrome patients, both STEMI and non-STEMI. The results that the infarct-related artery-only PCI was associated with a significant reduction in all-cause mortality or renal replacement therapy like hemodialysis at 30-day follow-up, because in this case you are going to use smaller amount of contrast, so minimizing the risk of contrast nephropathy and the myocardial depressant effect caused by the contrast. At 1 year follow-up, mortality did not differ significantly between the two groups. So the infarct-related artery PCI was associated with reduction in the complication, and at 1 year follow-up, the PCI here of all vessels did not reduce the long-term mortality. So the recommendation is to restrict the PCI during index procedure to the infarct-related artery only. So there is a class 1 recommendation for infarct-related artery-only PCI during the index procedure in case of acute coronary syndrome and cardiogenic shock, and then staged PCI for the non-infarct-related artery should be considered as a class 2A, either before hospital discharge or after hospital discharge, based on the results of the shock trial and the culprit shock trial. The second situation, a patient with STEMI, but he is hemodynamically stable, and coronary angiography showed a culprit vessel, which is the infarct-related artery, and another non-culprit vessel or more. In the previous ESC guidelines for STEMI in 2017, they recommended non-infarct-related artery PCI during the index procedure because all the clinical trials at the time performed multi-vessel PCI in that time frame. However, the complete trial, which is a famous trial assessing multi-vessel revascularization for STEMI, the non-infarct-related artery PCI in those patients allocated to complete revascularization was performed in 67% of cases during hospitalization and 33% after discharge at a mean time of 23 days, but always within 45 days. So there was no treatment effect by the timing of PCI interaction, and that's why performing PCI for the non-culprit vessel during the index procedure is not a must. it can be done during the index procedure or after discharge, but within 45 days. So the optimal timing for revascularizing the other non-culprit vessel still has not been investigated in adequately sized randomized trials with a superiority design. That's why no recommendation in favor of an immediate versus a staged non-infarct related artery PCI, and so the recommendations that there is a class 1 for complete revascularization in STEMI patient either during the index PCI procedure or within 45 days according to your clinical assessment for the condition of the patient and for the status of the affected vessels, and it is recommended that PCI of the non-infarct related artery, of course, is based on angiographic severity. And the big no that the invasive functional assessment of non-culprit segment, let's concentrate, I mentioned here non-culprit segment of the infarct related artery. I didn't say non-culprit artery. So the infarct related artery should not be subjected to any functional assessment during the index procedure, because PCI of the infarct related artery should not be postponed based on invasive functional assessment like FFR or IFR, because the coronary microcirculation begins to recover within 24 hours of primary PCI. And so the acute functional assessment of the infarct related artery may underestimate the hemodynamic severity of the coronary stenosis. Beyond 1 week of the acute event, FFR measurement has been reported to be accurate and predicting the abnormal nuclear imaging results. The third situation is a patient with hemodynamically stable non-ST elevation acute coronary syndrome and the coronary angiography showing multivessel coronary artery disease. So far, there is no dedicated trial comparing complete revascularization against infarct-related artery-only PCI for those with non-ST elevation acute coronary syndrome. All the trials were for STEMI patients. The observational studies and meta-analyses of non-randomized studies suggest that complete revascularization is associated with less mortality and major adverse cardiac events during follow-up than the infarct-related artery-only PCI. However, these results should be considered as hypothesis-generating at best, and still there is a gap of evidence regarding the issue of complete revascularization versus infarct-related artery-only PCI in non-ST elevation acute coronary syndrome. Regarding the non-infarct-related artery stenosis severity, should we evaluate the lesion significance by angiography only or the functional assessment? There is a large debate regarding this issue because overestimation of the severity of non-infarct-related artery lesion during primary PCI, if it was assessed by quantitative coronary angiography, is common as compared with repeated angiography, for example, within 9 months. Why? Because sometimes a microvascular constriction may occur also in the non-infarct-related arteries, resulting in variation in the functional measurements by FFR or IFR between baseline and follow-up angiography, and also may impact the severity on angiography, so affecting the decision making. In the FRAME AMI trial, it compared selective PCI guided by FFR to routine PCI guided by angiography in patients presenting with MI who have undergone successful PCI for the infarct-related artery. The result that the primary endpoint of death, MI or repeat revascularization occurred less frequency in those randomized to the FFR guided strategy. However, this study was terminated early and there was a relatively small number of primary outcome events, so you cannot generalize the results of this trial. In a sub-analysis of the FAME trial, it reported that 65% of lesions in the angiographic severity range of 50 to 70% diameter stenosis and 20% of lesions in the range of 71 to 90% have a FFR value of more than 0.8. So they are not functionally significant despite the intensity or the degree of stenosis. And it reported that the adoption of FFR to guide PCI resulted in similar risk reduction of MACE compared with patients with stable angina with a lower number of stents implanted and less contrast media. So FFR here was similar to the angiography-based PCI regarding the major adverse cardiac event, but it reduced the number of stents and contrast amount. In a meta-analysis of 10 randomized clinical trials, it assessed the outcomes in patients with complete revascularization versus infarct-related artery-only PCI according to whether the decision to carry out the non-infarct-related artery PCI was based on angiography alone or FFR as well. The results that the preventive PCI of the non-infarct-related artery was associated with a significant reduction in cardiac mortality and non-fatal AMI only when the decision to proceed was based on angiography alone. So there was a superiority here for the routine PCI based on angiography. And another meta-analysis of 7 trials, patients randomized to the complete revascularization, the angiography guided strategy for non-infarct related artery lesions was associated with a lower rate of recurrent MI, whereas an FFR guided PCI was not associated with this reduction. In a pooled post-hoc patient-level analysis for 3 famous randomized trials like the FAME, DYNAMI, and famous non-STEMI trials, acute coronary syndrome patients treated with functionally complete revascularization strategy, meaning PCI of the stenosis with FFR less than or equal 0.8, and deferring to medical treatment for those with FFR more than 0.8. It reported that the residual Syndex score was not associated with MACE at 2 years, suggesting that it may be safe to defer the management of functionally non-significant stenosis in the non-infarct related artery. So there is a lot of debate and controversy between the results of multiple trials and meta-analyses regarding which is superior, the routine PCI based on angiography or the FFR based PCI, but we are all speaking here about non-infarct related artery. So the recommendation so far for those with hemodynamically stable non-ST elevation acute coronary syndrome and the multivessel disease, that complete revascularization is just class 2A for those patients during the index procedure, and functional invasive evaluation for the non-infarct related artery severity using FFR or IFR during the index procedure may be considered just class 2B recommendation. The last topic and an interesting term to speak about today is the hybrid coronary revascularization. What do we mean by it? It is combined or consecutive procedures consisting of minimally invasive left anterior mini thoracotomy or robotic assisted to insert a lima to the LAD. So here undergo surgery for the LAD plus PCI to the other non-LAD vessels for the treatment of multivessel disease. So we combine surgery for the LAD and PCI for the CIRC and or RCA. The rationale here is to get the prognostic benefits of an arterial graft to an LAD with a minimal occlusion rate and the benefits of contemporary PCI with drug-eluting stents for the other vessels like LCX or RCA that would be otherwise revascularized using venous grafts that are prone to occlusion. So you get the benefit of the lima to the LAD and you get the benefit of PCI to the other vessels and avoiding the median sternotomy and decreasing the surgical mortality and morbidity. So far there is limited evidence from randomized trials regarding the hybrid revascularization, and that's why decision making in this regard should involve the heart team discussion to recommend whether hybrid revascularization would be beneficial and suitable for those patients or not. There are some clinical criteria that may help to support the hybrid revascularization strategy in acute coronary syndrome patients with an indication for CABG. For example, multivessel disease with LAD suitable for CABG and the non-LAD lesion suitable for PCI, patient having atheroma in the ascending aorta, so anastomosing the venous graft to the aorta would not be optimal, unprotected left main coronary artery disease that is unsuitable for PCI and still there are other vessels affected, complex LAD disease not suitable for PCI, advanced age or frailty, so you want to avoid median sternotomy, low LV ejection fraction, diabetes or CKD which increase surgical mortality, so you want to shorten the duration of the surgery, prior sternotomy, and lack of available bypass conduit, like for example patients with peripheral arterial disease, so you want to get only an arterial graft for the LAD and avoid using venous grafts. So the final conclusion as a recommendation for those with multivessel coronary artery disease that we should base the revascularization strategy either infarct-related artery PCI, multivessel PCI or CABG on the patient's clinical status and comorbidity plus the disease complexity according to the principles of management of myocardial revascularization. And we end the video with this interesting diagram regarding patients with acute coronary syndrome undergoing PCI of the infarct-related artery with angiographically significant stenosis in one or more non-infarct related artery. If a patient is having cardiogenic shock, so just immediate PCI for the infarct related artery, then staged complete revascularization. If the patient is having hemodynamically stable STEMI, complete revascularization either during the index procedure or within 45 days. In those with non-ST elevation acute coronary syndrome, complete revascularization during the index procedure as a class 2A, and you may undergo functional invasive evaluation of the non-infarct related artery during the index procedure. So we have reached the end of our video today, and our take-home message that decision making regarding the modality of intervention and revascularization for any acute coronary syndrome patient should be based on evidence-based recommendations to get the maximal benefit and minimize the hazard, plus the heart team discussion to decide which modality is the best regarding the prognosis for this patient. So both are complementary to each other. Thank you very much for watching this video, and wait next week for another video in the guidelines of acute coronary syndromes.